Thank you, Ajay, for this wonderful opportunity. Now, I shall be talking about corticosteroids. Corticosteroids mainly have a role in macular edema and not much for proliferative. So I'll be generally talking about macular edema. A big question which most of us ask is anti-VEGF. We all know center involving DME we inject. But do you keep on injecting hoping that the macular edema will resolve maybe after 7th or 8th injection? Or do you take a rain check at 3 injections, and if the patient is not responding to anti-VEGF, switch over to corticosteroid? I'll give you a situation. This is the OCT. You can see there are large spaces, fluid-filled cavities. There is fluid, and you can look at the photoreceptors. They are under stress. They are detached for quite some time. So patient has already received 3 injections of anti-VEGF. The big question is, would you add steroids or would you still continue with anti-VEGF? Now, before we go ahead, let's answer a very basic, simple question. Is macular edema caused only by VEGF? Not really. Diabetes affects all cell types. It affects retinal vessels. A lot of attention is paid to this aspect: choroid, glial cells, and neuronal cells. So what happens is, when there is chronic hyperglycemia, there is loss of retinal capillary endothelial cell tight junctions. We all understand it very well. This causes 2 kinds of reaction. It produces inflammatory mediators as well as VEGF. Both of them increase the permeability and the macular edema. However, when we are treating, most of our focus is on this leg, and we tend to ignore this part of the treatment many times. So, coming back to the same, that once the permeability is broken and there is the cytokine exposition, it is a kind of a vicious cycle. So, sorry about this. Even if you are taking care of anti-VEGF, you still have lot of inflammatory mediators which are further increasing the capillary permeability and contributing towards the development of more macular edema. Besides the retinal capillary permeability, we also have retinal microglia and macroglia, and these glial cells become activated by hyperglycemia. They respond to the stress and they also produce TNF, interleukins, and VEGF. Now, when we are giving VEGF, VEGF is not taking care of these cytokines, because these cytokines are attracting more cells which are coming to the retina. So there is a very interesting study which I personally liked a lot. This was about studying the phenotype. I won't go into the details, but if you have the macular edema, which is the leaky variety, which is the mostly diffuse or the serous, this is mostly increased due to ICAM, whereas the ischemic is the one where VEGF levels are very high. And you can see, once you inject VEGF into the eye, you end up with ischemia and microaneurysms, which means when you are treating with anti-VEGF, you will be able to take care of this component, but the other component, which is breakdown in the blood retinal barrier, is mainly driven by non-VEGF components, which we need to take care of by giving corticosteroids. So we come back to our basic question: persistent edema after 3 injections, what are the possibilities? 1, this phenotype being treated may not be VEGF driven, because there are cytokines which are working. There are mediators other than VEGF which are not being targeted, hence you have edema. And anti-VEGF on their own are not able to improve the drainage or reduce the swelling of retinal molar cells. So they need a bit of help. And that help would come with the introduction of injection of corticosteroids. Protocol I was carried out to assess whether early response to anti-VEGF after 3 injections can predict long-term treatment outcome in diabetic macular edema. So very interestingly, what they showed that after 3 injections, whatever improvement in the vision occurs, that is what stays on the long-term period, which means that if after 3 injections you are not having improvement, you are not likely to have improvement in the long term. So probably this is a time to switch over the therapy from anti-VEGF to steroids. This is an example of a patient here I showed you in the beginning. So you can see here there is a breakdown of the blood retinal barrier. There is this, so he received an implant at this stage, and you can see 3 weeks later vision improved to 20/30, and there was a good response to steroid at this stage. Subsequently, he was actually maintained on anti-VEGF injections, and this is 18 months later with the vision of 20/30 being maintained. So etiology, we all understand, is multifactorial. So anything which has a multifactorial etiology, treating it with monotherapy, talking only about anti-VEGF injection, even the common sense defies it. If the etiology is multifactorial, the treatment has to be multifactorial. The second role of implants which we use is at the time of surgery. This is an example of a patient who has vitreomacular traction, undergoes surgery, and 3 months post-op you can still see the residual spaces. However, this is another patient who has TPHM, undergoes surgery along with steroid implant, and within 2 weeks you can have a very quick post-op rehabilitation. And the last leg is to minimize the progression of diabetic retinopathy following post-cataract surgery. We are injecting steroid implant, and we have recently completed a series, very large series of 140 patients with good positive result. This is an example of a patient before, and this is after cataract surgery. So conclude, steroids do have a definitive role to play in the management of diabetic retinopathy. You have to customize every patient rather than following the trials, because when you are sitting in the clinic, patients, honestly, believe me, do not follow the clinical trial patients. So I think customization is very important. Thank you.